Hello, everybody, and welcome to HRN, the HRN Show. I'm Alex Grichuhin, the Director for Advanced Lung and Heart Disease. Today's topics, we're going to be discussing, there's a new telehealth news. There's by M Health Intelligence. You can look that up online anytime at mhealthintelligence.com. The review was based off of a video telehealth quality largely on par with in-person care. So what this is talking about is there was a large study between in-house or in-facility care versus virtual. And we've brought this up quite often, many times, but there is another study being done, and I'm going to be discussing this study. Also, if you haven't done so already, please like and subscribe on our social media pages, especially with YouTube, Facebook, Instagram, and Twitter. Now, well, let me bring it up like this. So telehealth has been around for like a little bit. It hasn't been around for a ton of time. Okay. Now, there might be somebody saying that, well, long time ago, a very long time ago, there was doctors calling in to patients via the telephone, and that is a form of telehealth. That is true. That is a form of telehealth. But what I'm talking about is the visual perspective, not just the audio perspective. So telehealth, when we look at telehealth, and when we talk about virtual, a lot of people will get that confused the same way as they look at fluid. Okay? A lot of people would think of fluid as being something of liquid. That is not true. Liquid is different. Fluid is also considered a what? Does anybody know? A gas. Yes. Of course.
I did not know that.
Yes. So fluid is also, and where do you get that information from? By simply looking up what is a fluid. That's it. That's very simple. Okay. Fluid versus gas. Remember, fluid is not a liquid per se. You can look at a fluid as a liquid, but that's not really the definition. So if I open up a container that was, let's say I open up this. It was this mug, and there was a and there was a lid on it. And I open it up. Gases will come into the cup, and basically, just not necessarily taking out the empty gas that was in, but it depending on the weight of it, will actually come in and fill up the whole entire container. Okay. I learned a lot about the difference between fluid. In case anybody wants to know, I looked into fluid versus liquid by going through my pilot license. And for those that don't know, I'm studying to be a pilot just on my leisurely time, basically.
Just for funsies.
Yeah, just for funsies, but it's more for other reasons too. But as I travel a lot. Anyways, so when somebody looks at virtual, they will tend to think that it's an automatic AI person, let's say, artificial intelligence type of person that will communicate with you. That's not what we do. Our virtual program is a telehealth program. Okay? And the only difference is that you're doing everything remotely, but you're able to see and hear everything the person is doing in real time, meaning exactly at the time the person is seeing it, you're doing it. Does that make sense? Okay, so our virtual program is a telehealth program where we're able to see and hear you in real time. So if somebody's sitting down, we'll see it because they're on video. It's like FaceTime. Anything you do is in real time, right? On FaceTime or Skype or Zoom, it's in real time. And of course, we use Zoom. So anyways, let me go over this really quick. So conducted by the California Health Benefits Review Program and the Philip R. Lee Institute for Health Policy Studies, the review includes studies published between January 2021 and October 2022. Researchers also included 80 studies that examined the use of telehealth modalities as a substitute for in-person care in the analysis for the report. The review includes research on live video, telephone-only, asynchronous communication via email, text, and chat, e-visits through two-way messages, or a short questionnaire on a health portal, store and forward telehealth, and hybrid care. So, the research review shows that the most modalities and services results in the similar health outcomes compared with in-person care. So let me read that out again. The research reviewed past tense shows that most modalities and services result in similar health outcomes compared with in-person care. Live video visits, in particular, have a preponderance, that's a word I haven't said ever, of evidence showing that they are on par with in-person care in terms of health outcomes, processes of care, and utilization of healthcare services. In the reports, the preponderance of evidence referred to the fact that the majority of study review are consistent in their findings that measurement is either effective or not effective. So, what this is showing is that in-person care that you would think it would be higher in outcomes are actually the same with telehealth. That's not higher, and telehealth is lower when it comes to outcomes and the whole constitute of telehealth in itself. So you can't say, and we already knew this, so somebody can't say that in-person care is better than telehealth. You can't say that now. Okay, we already knew this in our program, as we found there was it was very hard to find clinicians that can see X, Y, and Z patients, from in other states, because of course there's a shortage of clinicians nationally, but also I would say worldwide. There's a large shortage of clinicians. So because of the large shortage, the only way we could actually see everybody is by doing it remote, and of course doing it in group settings. Okay, so when we look at the review process, and we're looking at the review process, this is a published paper. This document is a published paper. This is basically stating that the results are, of course, nearly identical. Now, of course, telehealth doesn't take away from people who need hands-on help. I'm talking to people that have major balance issues. Now, if they have, let's say they have a complication like that, they have major balance issues and they have to stay in the wheelchair. Can telehealth still provide rehabilitation or virtual pulmonary rehab to that person that has balance issues? Yes, of course. Of course. It's not contradictory. It just means that through telehealth, we wouldn't probably have the person stand up just yet. We'd have to fix up the underlying conditions and seeing if we can resolve those conditions, those problems, to make that person being able to do things, okay, like exercising. Do we have any questions on that?
Everyone's saying good. Everyone's saying good morning.
Good morning. Okay.
Sorry.
Well, good morning, everybody.
Before I have my question, I want to say congratulations to Michelle because she got her certificate of completion of COPD disease management.
Good.
So congratulations, Michelle.
Congratulations.
But keep working at it. Remember, it's a progressive disease.
Yes.
So.
We find a lot of people that go in through any pulmonary rehab program, you have to understand, too, that a lung disease, specifically like COPD or even idiopathic pulmonary fibrosis, that you have to keep up on with exercises, as it's a progressive disease. It gets worse and over time. Okay? It doesn't mean that, it's not like you're trying to find the cure. But if there was a cure to, let's say, lung disease, I would say that pulmonary rehab would be the closest one to it, as that the outcomes out of it kind of speak for itself. You get a heightening in lung functions. It'd be different if you're doing everything you can. It would be different if you're doing every single thing you can and you're making no improvements. But if you're improving, you're obviously not getting worse because you're improving, not declining. Okay? So we don't like people to, so we don't provide a program that maintains somebody the same exact way as when they came in and when they leave. All right, those types of programs are not something that I would think would be beneficial to somebody, because if somebody's trying to get into pulmonary rehab and they have a lot of problems, they feel the same way. They feel the same way in outcomes as they come in as they leave. Well, that just shows that there's no results besides the result of them not progressing, not doing better. Does that make sense, everybody? So you want to look at and understand that when somebody chooses a pulmonary rehab program, they should always look at the outcomes, not just the convenience. Our virtual program is very convenient because you can pretty much do our program anywhere around the world, as long as you have a device.
As long as you have data and internet.
Yeah, as long as even if you don't have internet, you can use a cellular device that uses the satellite uplink. So it's very simple. Okay, so there's no excuse. But the other thing is, yes, we are very convenient, but the outcomes for us is what really makes our program very unique, because we have a very extremely low hospital readmission rate, which is the national lowest, which is a very good thing to have. And we have a very high compliance and patient success rates. Very, very high. So meaning that the chances of you staying the same with us is ultimately non-existent. Okay?
I'm glad you said that, Alex, in terms of bringing up the convenience factor of it. Because I wanted to get your opinion. Do you think that it's a case of it's not as mainstream being telehealth? Like, you see movies, TV shows, everybody goes to the doctor. You know
Sure.
what I mean?
Yeah.
So do you think that's a factor as well?
Give me an example. What do you mean?
So when people say, oh, I have to go see my doctor, they don't immediately think, oh, I can call up my doctor and schedule a telehealth appointment.
No, they sometimes don't think that the representative in that doctor's office might suggest, hey, you can do it through telehealth. We can get it through Zoom or something, and they can just do it that way, and that's fine. But as far as doctors go, a lot of doctors understand pulmonary rehab, but they don't understand the concept. They also don't talk to their patients about joining into a pulmonary rehab program, and we found that to be very, very, very common.
Well, I think we take it to the next step, in a way.
Yeah, absolutely. I had the privilege and honor to visit George Washington Hospital in D.C. I have to admit something that I haven't seen for a very long time, is passion. I went into the respiratory department talking about the Delta V and talking about outcomes, talking about how to get somebody to walk from point A to point B, how to go upstairs, all sorts of things. And each and every single one of the RTs in that department were completely focused in the meeting. They were focused. They were asking great questions. They were also asking questions to better enhance their self as far as clinical capabilities go. I find that very, very, very rare in any pulmonary department. Not saying any respiratory department is bad, but I have to really say that the George Washington, the GW hospital, I have to put them on the top of my list as a hospital I would recommend a patient going to, specifically for respiratory care. And that's very rare for me to say. Okay, but I really have to admit that they not just know they know the game. They really do know their department extremely well. But when I was bringing up different things, different applications you can attach a Delta V to, they wanted to see if they can add it to this. They wanted to see if they can add it to that. Great questions, questions I've never heard from anybody else say, because they want to learn more. They want to do more for their patients. They wanted to make a difference in their department. They want to make a difference in the hospital. Those types of therapists are the top number one therapist I would always look at as a possible employee of HRN itself. Okay? And that's rare for me to say. But I'm stating that if you ever gone to GW, if you ever been to GWMC, if you ever been to the George Washington Hospital, I would suggest, especially for respiratory problems, that would be my top pick. So if somebody's asking me which hospital would you pick, that would be my top pick right there. Just from the department. I'm not saying any other hospital is bad at all. Okay, all I'm saying is that their department and everything, maybe I caught them at the best time, but their department was fantastic. Everybody in that department, every respiratory therapist in there were extremely knowledgeable. And the other thing is, they also wanted to learn more. That's the thing I see, is that let's say you have a respiratory therapist that doesn't want to hear a good way to, or a good outcome, a good technique for their own patient, because they feel like they know everything. Then all the information you give them goes in one ear, out the other. So it's been, it was definitely an honor and definitely a privilege to be over there talking about our Delta V, our respiratory muscle training, talking about how we enhance somebody's well-being, how pulmonary rehab, and of course they're wanting to partner with us, and that's great. But I have to give my hat out to them. They just a fantastic department all the way. So kudos to GW.
It's very rare to find just individuals in general that care that much, that they're always willing to learn.
Yeah, because you realize that you're not the only one fighting for all these people. It's always so good it's always nice to know, and I know there's a lot of them out there, but a lot of those clinicians don't get recognition for that. And so I'm doing it on this show, just recognizing those top departments. And that one department, the RT department, respiratory therapy department, the pulmonary department, over there, it was just fantastic. It was just fantastic. It was just absolutely, I was just blown out of the water. I was just really blown out of the water from it. But yes, they're a fantastic group.
So we do have some comments.
Please.
One from Kenny from Facebook. He says, "You guys are great. I started in September. I was on 3 liters of oxygen, and I am now off. Only use it at night by his BiPAP. So keep up the good work, Kenny."
Yeah, that is one thing. If somebody's trying to wean off of oxygen, there's a chance to wean you off oxygen, even if you've been on it for 6+ years. There's a chance with us. Of course there is. Okay, so don't think, or don't get from somebody that, oh no, that's going to be a permanent thing. No, nothing's ever permanent unless you want it to be permanent. Okay, if you're just not strong enough, then we'll get you stronger. If you can't breathe well, we'll just get you breathing better. That's just the way it works. Okay, but you also want to take in part of the anxiety issues that also come in hand when somebody has a hard time breathing and they're thinking that, oh, it's my lungs acting up and not necessarily my anxiety. We always want to take account for that, for stress management being a very key component in pulmonary rehab. You always want to make sure that any pulmonary rehab group you join, they have a stress management sessions, that they actually do stress management. Okay.
We have another comment from Ernest from YouTube. Says, "Hi guys. He unfortunately had an exacerbation 2 weeks ago.
I'm sorry to hear that.
But was strong enough because of his workout routine. It kept him from having to go into the hospital. Staying healthy is key."
Excellent. I also want to bring about the exacerbations, and that's Ernest. Thank you for mentioning exacerbations. I am sorry that you went through that, but I'm glad that you knew what to do and how to stay out of the hospital. When it comes to exacerbations, there is a delay in recovery, because as soon as anybody gets sick, you might find that your lungs feel like you feel like you're going backwards when you get sick, and that happens. That happens very often. In fact, I don't think there's no one I know that actually it didn't happen to. When that happens, it doesn't mean that you're actually going backwards. It just means that there's a small delay. Okay, and that's going to happen anytime you get sick. Unfortunately, this program doesn't prevent you from getting sick. That's just what happens in the world when you touch a contaminant and it enters into your body. Okay, but the delay pattern, meaning that when you get sick, there might be like a 2-week delay in going back to where you were before. Okay, but don't let that discourage you, because that's just a temporary problem. Temporary problem. All right, but if we use medications, only medications, and not rehabilitation, you won't get the outcomes you want. So I have a patient that was feeling like he was going through an exacerbation. I called the doctor, and the doctor's office talked to the nurse, and they were actually pretty good at making sure that person not just stays out of the hospital, but gets what they need. Okay, and the patient calls me up saying, "Alex, I'm still feeling shortness of breath." I said, "When?" I said, I understand. How out of breath are you?" And so on and so forth. The questions I'm asking. So the patient responded that they're taking their medications, they're taking their antibiotics, they're taking their prednisone, they're taking their medications, but they're not finding a huge relief in their symptoms besides their sickness is dying down, which is great. You don't ever substitute medication with exercise, ever. So the fact that that person might be feeling out of breath, sitting still, it's not necessarily, I would say, the medications. It could be a symptom of the medications, like the side effects of the medications. But if I asked the person, "Are you doing any rehabilitation?" They said no. I said, "That's your problem. You're sitting still waiting for these medications because you feel the medications should fix you 100%. But you forget also that from all the scarring that's developed from being sick, those medications won't fix that. There is no medication that fixes that. So you have to get up and move." And he said, "Okay, I'll start." And once the person started, then they start feeling better. It's always like that. So you never substitute a medication to fix yourself. Okay? At least you shouldn't. There are some medications that are required depending on the complication that's there. But you always want to take account. Never use a medication to fix your out of breath problem. It's a ventilation issue. It's not a medication problem. Now, of course, if you have asthma, you have to take a medication to dilate, but you still have that issue with work of breathing. That could be because you might not, you're sitting down too much, living a sedentary lifestyle too much. You're sitting down, you're not moving as often. Well, you definitely want to incorporate exercise, of course. And for those that don't know, where can I find a good exercise routine for cardiac and pulmonary health? Does anybody know?
My New Lungs.
You can go to My New Lungs, but a good resource to use is not just the My New Lungs, but printing out a PDF file of the Bronson's cardiac and pulmonary program. It'll just give you exercises, things that you can do. It won't give you a lot, but it will give you a good summary on exercises and what you should do, what you should talk to your doctor about, your limitations, contraindications, things of that nature.
Pamela agreed with me on that one. My New Lungs.
Yeah, I know. My New Lungs, yes, that's a very, very good resource to use. But if I'm just talking about like a printout,
Yeah.
just a printout of maybe a workout schedule or something that you want to add into. The Bronson's guide is all you have to do is just type on Google Bronson, BRNSON, Bronson guide, and that's all you have to do. Bronson's guide. You can put Bronson's guide pulmonary rehabilitation. That'll come up too. So those resources are free, by the way.
So Alex,
yes.
So we have some questions here, but before we get into them, would you like to tell us about My New Lungs?
Yeah, so on My New Lungs, yes. So My New Lungs, it's a self-paced program. Self-paced program. You might feel that self-paced, you do it only on your leisurely time, wouldn't be very beneficial. That is not correct at all. But as you can see, a lot of people that use My New Lungs benefit greatly. But on My New Lungs, it's a self-paced program. There are different levels that you can participate in. You can use the platinum level, which is the highest level. And with the platinum level, you will get me for about 15 minutes a week. And all I do is I'll just schedule with you, or rather you'll schedule with me about 15 minutes out of the week. And all I'm going to do is just making sure that you're progressing, you're getting better. If there's any tips, tricks, questions with your medication, you have all the autonomy to talk to me for 15 minutes. Sometimes it can be a little bit more, but it's usually about 15 minutes. And you just, my job is to make sure that you get through the program and you're benefiting from the program. So I want to see results. I want to see questions. I want to see everything. Okay. The other levels, which are still fantastic, they're self-paced, but you won't get me. You won't have me for 15 minutes a week. But needless to say, you can always ask questions. And to ask questions to me, if you want to ask a question to me, like specifically to me, just all you have to do is just on an email, open up an email and just type in Alex, the @ symbol for email, @ mynewlungs.com. You just email me on alex@mynewlungs.com, and of course I will respond personally. Okay, if you have specific questions.
And make sure to keep up to date with all of our social medias for new content regarding My New Lungs, HRN, and Delta V.
Now, what about the My New Heart? The videos that you're working on with Dr. Selsky, when are those going to come live to fruition?
So currently, to my knowledge, we are working on, and this is more of a Jordan question, but My New Heart, he's working on building the website in general. And then, as you mentioned, I am currently on video number 10 of the 30 videos, so that had to be done by January the 2nd. Yeah. So
Dr. Selsky has been, Dr. Selsky and John, and of course Jordan, have been working very intently on the new cardiac program, which people know that we do have a cardiac program, but this one also has Dr. Selsky, which is our chief executive director for cardiac. And he's a cardiologist, a very seasoned cardiologist, and he's very extremely passionate about cardiology and the rehabilitation of cardiology. He's going way above and beyond, So that's what we expect from our doctors and our therapists, is going above and beyond for the patients. But he's definitely doing that without constant reminder. Is like, get on the ball, and get these things going. He's on top of it, definitely. So be on a lookout, because that's happening very soon. That our cardiac, which will be My New Heart, will also be coming out rather soon, especially this year. In 2024.
Alex, can you confirm your email? That email again, it's alex@mynewlungs.com?
Yes.
Okay. I just wanted to confirm that because Janet was looking for confirmation.
Yes.
Of the email.
Yes. Absolutely.
So
absolutely.
Take a look in the comments section here, Janet. I added it there for you. Anyway, so actually, before we do move on, I wanted to reiterate it'll be similar to My New Lungs, the format of My New Heart.
Yes, it's just it's specifically cardiac.
Yeah, it isn't pulmonary. It's specifically cardiac, like you said. So there's 2 questions, Alex. Well, actually now 3.
I love it.
So this first one is a lighter one. It comes from Lynn from Facebook. Why does my voice go out during COPD exacerbations? Does this happen to others because all the doctors I've been involved with and tested with act like they have no clue, and I'm the only one that experiences this?
So around the vocal cords, when we cough a lot, especially during exacerbation, so you have these very extremely thin membranes. It's just around the epiglottis area, and you have your tourniculate and corniculate, and basically the vocal forms open up. When you cough, the epiglottis sits flush, and it basically creates a seal where you obtain a cough, so that that popping sound is caused from your glottic closure when you cough. So anytime we're coughing, especially violently, it does tend to loosen up those membranes, and of course your voice will change because of that. Can it also be a result? Can it also be a result of medication use when I'm inhaling a medication? Yes, that could happen too. Yes, because the airway, your airway with the vocal cords, if medication is, let's say, some of them dry powder got onto your vocal cords, could cause some problems there. But the problem should only be temporary. We haven't heard anything extremely adverse as far as that, unless somebody just got extubated.
So no permanent damage, basically.
Yeah, it shouldn't be a permanent damage. From what I've seen, it shouldn't be a permanent damage, no.
Pamela says that this happens to her also. She thinks that it is the medication.
Yeah, it could be medication, but definitely if somebody coughs, so like if I cough very, very violently, my vocal cords will change, my voice would change a little bit. But then it just goes back and resolve back to normal again.
So this might be a dumb question.
No, what's up?
But could the anxiety and the breathing, I guess, quicker be like drying out the back of your throat, and that affect it as well? Do you think? Could that?
That shouldn't happen. Mm-hmm. It could possibly. I'm only seeing a couple reasons why it could, but it shouldn't affect it. It's like a drum. Drums are dry, right? Mm-hmm. Okay, makes a sound. You wet it. If you wet the drum, then it dulls it out a little bit, right? But the thin membranes are so thin that most of the time there is humidity there, but it's not necessarily completely dry, of course, in the vocal cords. If it's medication, if it's from coughing very violently, even if you just got extubated. When you get intubated and extubated, so when you get extubated, the cuff around the endotracheal tube will sometimes hit the vocal cords a little bit, especially if it's crystallized. Crystallization of a cuff is based off of long-term exposure of intubation. So when a cuff comes in, and what I'm talking about a cuff is a trach tube or endotracheal tube, a longer tube. The very bottom of that tube, like near the bottom, you have this balloon, and that's called the cuff. Well, that's inflated to about 22 to 25 centimeters of water. Okay, it could be an LVN cuff, but as it opens up, it keeps the tube in place. But that little small diameter is where the person breathes in and out through. So breathing to that resistance is very hard. And of course, that person can't talk when they have an endotracheal tube in. Okay, even with a tracheostomy, you still have a hard time coughing. You have a hard time talking, unless you have a Pachymeres or a Shikani valve in there. But if you leave that cuff in there with long-term exposure, the cuff it will actually start crystallizing, hardening up. So when they deflate it, it doesn't actually deflate all the way. And this happens often. When they pull it out, well, what comes as they're pulling it out, what happens? Well, the vocal cords will actually sometimes get damaged from the crystallization. And when they pull it out, the person will have a lot of adverse effects, especially talking difficulties, communication difficulties.
Oy.
I know. I could talk a lot about it, but I'm trying not to bring up too much medical lingo on it.
That just sounds, without a better term, rough.
Yes, it is very rough.
To put it bluntly.
Yes, it is very rough.
So we have a question here from Mary. It's a long question. So
sure.
She says, Pamela says, yikes. So we have a question here from Mary. She says, I experience chest tightness, sometimes stabbing sharp pain, and pain to the touch on the left side of her chest over her heart to the middle of the chest. She's been to the ER multiple times and seen a cardiologist.
What did they say?
She's told that her heart is good, that it's possible, and forgive me if I mispronounce this.
It's okay.
Costochondritis. She says she still gets these and won't go to the ER She is curious if you've ever had anyone experience this.
I mean, we've had different types of what we call angina. Angina is spelled A-N-G, angina, I-N-A. You just have to type it up, but that's a general term for chest pain. Any chest pain at all, and kudos for going to the emergency room, because anytime if anybody ever relayed information about chest pain, the first thing I want them to do is go to the emergency room and get checked out. Because any chest pain, it's always an emergent condition. Okay, at least that's our thought process behind it. Now, if you go to the emergency room and they find nothing, then it was nothing. But if somebody ever states they have chest pain, definitely you always want to go to the emergency room. Okay, you never play with that. You never mess with that. Have I ever had patients that had angina? Yes, a lot of them. Particularly that, I don't think so. I don't think I can ever recall somebody having that specific problem. Okay. That being said, doesn't mean that there isn't something to do about it. I would have to research a little bit more to see what I can come up with, and especially talking to my peers, my fellow doctors and respiratory therapists about if they ever heard of something like that and what was the best source of outcomes. You know, I'll give that information as soon as I obtain it.
Thank you, Alex.
Of course.
So we have...
Great question, by the way.
We have on another note, Michelle asking, is it possible do we have any free videos for COPD exercises? So Michelle, we have our YouTube channel, which offers quick tips and
Yes.
Different insights into respiratory health and different things, and we're going to be adding cardiac videos once those get filmed and everything. So
I wish we can do everything for free. I really do, because there's a lot of people that need it. The only thing is that the expenditures of paying the respiratory therapist and paying for the overhead and everything is just not realistic unless we were being funded by a university or funded by a state or something, and that's not like that.
Yeah.
You know, they're trying to pull a penny out of the state is very, very difficult.
Yeah.
Very difficult. Even if it's just for the well-being of patients, people in general, it's just very, very difficult.
And then, Michelle, regarding your question regarding insurance, it's unfortunate that we don't take your insurance. However, My New Lungs is also another option.
Yes, My New Lungs is a great option if you don't have insurance.
Especially the Platinum Pass, like Alex had mentioned previously.
Yeah.
Anyway, so Diane asks, she says, I have COVID. Is it normal for it to be hard to use the Delta V with COVID?
Absolutely, especially with coughing. Every patient I've ever had that had COVID cough very, very violently, and especially when they're breathing in through it, they'll cough, and they can't keep the darn thing in their mouth to keep going. That's going to happen, but you want to keep using it. So even if the cough is initiated when you breathe in a little bit deeper, what's happening is the lung parenchyma and all the scarring is agitating your lung field because of all that scarring. It's like having a balloon and having a band wrapped around the balloon. Well, that band that's wrapped around this made-up balloon, as it expands it's pulling up and agitating the lung parenchyma and agitating the airways, which will cause you to cough. But as you keep going with it, especially doing with respiratory muscle training, you'll find that your cough will slowly start increasing on volume, meaning your cough first was initiated, let's say at 1,000 or 500. Then you'll find after using the respiratory muscle training, still going through the cough episodes, you'll find that your maxed out at 1,000 is going to go to maxed out at 1,500, then maxing out at 2,000. So your cough, that glottic pharyngeal spasm, that cough, won't be initiated until your volume increases a little bit more. All you're doing is moving your agitation over. I know it's a little difficult to understand, but let me bring it up like this. Okay, you have a lung, and you have scarring on it. Now, of course, this band is very large, but let's say we have scarring on it. Okay? As soon as I inhale and I put tension on that scar, I'm going to start coughing. So, and let's say when I checked it on my volumes, I started coughing at a volume of 1,000. So every time I breathe in 1,000, I'm going to cough. Now, if I breathe in, I'm starting to cough, but I keep trying to add in air, that cough, that irritation won't be there at 1,000 anymore because I'm overstretching it. I'm stretching the scarring tissue, and eventually my scarring will be more compliant. My lungs will be more compliant, easier to inhale and exhale and inhale and exhale. Okay, so what you're doing is you're moving the, you're not necessarily moving the scar tissue, you're just making the scarring more compliant, where before it was very stiff and now it's very loose. So would it still be showing up on x-rays? Absolutely. But your lungs are compliant based off of your pulmonary function test. I know it's a lot of jargon, and like I said, this is a science and an art, but it's a science, and it's just a lot of information. But it's necessary information. Any other questions?
Well, Mary says thank you. Thank you for that. And Diane also says thank you.
Absolutely.
For that
Absolutely.
information.
Well, let me, just real quick on cardiovascular health. What are the benefits? Does anybody know the benefits? Let me go over some of the benefits of cardiovascular health. The benefits include increase in cardiovascular fitness, increase in increase in muscle strength and flexibility, improve in joint mobility, decrease in stress level, improve posture and coordination, strengthening bones, decrease body fat levels, prevention or management of disease, and reduction of anxiety and depression. Specific health issues with cardiovascular is people that are obese and, of course, the weight control. Cardiovascular disease, including stroke, high blood pressure, and heart attack, regular cycling stimulates and improves your heart, lungs, and circulation, reducing your risk of cardiovascular disease. Cycling strengthens your heart muscles, lowering resting pulse, and reduces blood fat levels. Research also shows that people who cycle to bicycle, so that's what it means by cycling, people who cycle to work have 2 to 3 times less exposure to pollution than car commuters, so their lung function also improves. Cancer research has shown that if you cycle, the chances of bowel cancer is reduced. That's interesting. Some evidence suggests that regular cycling reduces the risk of breast cancer as well. Cycling also improves strength, balance, and coordination. It may also help prevent falls and fractures. Riding a bike is an ideal form of exercise if you have osteoporosis because of its low-impact exercise that places little stress on joints. Mental health. The mental health conditions such as depression, anxiety, and stress can be reduced by cycling regularly. This is due to the effect of exercise itself and because the enjoyment of riding a bike can bring. So things to remember. Cycling can help protect you from serious diseases such as stroke, heart attack, and some cancers, depression, diabetes, obesity, and arthritis. Riding a bike is healthy, fun, and low-impact form of exercise for all ages. Cycling is also easy to fit into your daily routine by riding to the shops, parks, schools, or around your neighborhood and work. There was a common misconception that cycling, that bicycling can cause a heart attack or exercise can cause a heart attack. I know a lot of people fear, especially if they have a heart attack, when the doctor says don't do as much exercise. That type of phrase and that type of wording should never be in place just because when somebody has a heart attack, there is some contraindications on some exercises. But the exercise itself, what constitutes as a good exercise is something that increases your heart rate. But we don't want that heart rate to go overboard, so what do? We in place target heart rates during your exercise. So exercising is necessary, especially if you have an MI, myocardial infarction, or a prior myocardial infarction. So exercise routines are incredibly important. Now, how much bicycling should I be doing per day? You want to try to get to at least 25 minutes a day. That's what you want to try to. I can't do it. Well, like I said, you want to try to get to 25 minutes a day. If you can get to 25 minutes on a bicycle, going at a good steady pace, you don't have to go vigorous. You don't have to go, you don't have to be too ambitious. But, adding some exercise like that to increase your heart rate will do nothing but benefit you. Okay. Now, if you have any concerns, you always want to talk to a cardiologist and talk about cardiac rehabilitation and what are my limitations on exercise. Get that information because they're going to look at your target heart rate. They're going to look at, okay, this is your target heart rate. I want you to stay at, 54 beats per minute to 110 beats per minute. They're going to do something like that. Instead of saying just cycle until you pass out. That's obviously not a place you ever want to go to. You want to slowly walk away from that rehab program if they do something like that. Any other questions?
We have something in here that, in the chat that I think would be good to address.
Sure, please.
And it is how do I word this? Looking up different lung exercises on like YouTube and why
again, I'll bring up YouTube again as I brought up before.
Yeah.
Okay, guys, we have to do our research. We're intelligent people, and there's a difference between intelligence and knowledgeable. Okay, my son the other day was asking me, Dad, am I stupid? I says, why would you ever say something like that to yourself or confused about that? Why would you think that I said, do you think you're not smart? And he says, yeah, I don't think I'm smart. I says, well, you're 9 years old, man. Give yourself a break. I said, but I want you to understand something, Jeremy. Your intelligence is all the way up to the sky roof, but your knowledge is a little far down because you don't have a lot of that experience. And experience is also a contained in knowledge. So your intelligence is very high. You take somebody who's never went to school but is incredibly intelligent. They will try to figure things out. Now, if they obtain some knowledge off of a book or through experience, then they're going to use that knowledge and kind of intertwine it, in a sense, with... For instance, my son was having a hard time tying a shoe. I didn't want to show him how to tie a shoe. I told him, I want you to research it. Something that simple. I know. It's like, what? If I did everything for my son will think... It will create a mental block for him that anything he has a problem, he'll just come up to me and I'll always solve his problem. So what I did, I said, research it. So he researched it. And then he came back to me with a tied shoe. I told him, pick up a shoe, untie it, and tie it back up. So he brought it to me, and what I did wasn't mean. I grabbed the shoelace, and I untied it. I says, tie it again. He says, okay. And he tried tying it. So what he's doing is, what I did was I reinforced what he learned. That's all. I'm just reinforcing it.
It's practice.
Yeah, practice. I find that if somebody does something the same exact way 5 times, they got a good habit of doing it that way. Okay? So what he did, he was researching it. He was going exactly what the video was showing him how to tie a shoe. Then I showed him a different way. So I actually picked up the shoe and showed him, this is the way I do it. This is the way somebody else would do it. What my point is this. Your intelligence is all the way up here, and you're trying to develop knowledge from YouTube to do lung exercises. Okay? There has been numerous of studies, and we should put this to rest. There's been numerous of studies that people that use only YouTube or other social media to obtain information of how to do something, the outcomes are very, very, very poor. Why are the outcomes poor? When I mean outcomes, I mean gaining benefits, getting stronger from the exercises itself. I'm not talking about lifting weights per se. I'm talking about, with pulmonary rehab. Let's say with pulmonary rehab, you're going into a self-paced program with no peer review. No one to overlook to see if you're doing it correctly. Because of that peer review, and just look at the AARC.org. Go to their website, American Association of Respiratory Care.org. It's an organization. It's free. look up YouTube. When they come up with the search, they'll have a search bar on the very top. YouTube outcomes. That simple. They found, and they took a large amount of people that used YouTube, and they saw the outcomes were less than, I believe it was less than 10%. I want to say it was 3%. But it was less than 10%. The outcome of the improvements were less than 10%. It wasn't even next to 100%. It was 10%. And the reason why is because there was no clinician overseeing their progress. Somebody's lifting exercise and they're lifting a weight, and they pick up a weight and they start lifting it. Their posture might be really bad. They might be lifting it too quickly, and they're trying to look at the video, but their technique is very off. Because of that review, I'm watching you exercise, your back is off, you're not breathing in deep enough, you're not doing a full rep, you're doing partial repetition. Because there's no one there doing that, helping you with your technique, the outcomes are very, very poor. So I understand that a lot of people want to go with something like, let me go to YouTube because it's free, it's easy, all right? But you also have to understand that on the study done by the ARC, and I'm sure there were the IRB planners, but investigative review boards. The actual organizations, I think it was a multitude of different organizations that made up the study. The problem they also had wasn't just because the peer review process. There was no one overseeing the progress, showing them the proper ways and stuff. It wasn't just that. It was also going on to YouTube and finding clinicians that were not clinicians. They weren't licensed in anything. Or they used to be licensed a long time ago, but they had their license revoked. Or they're not even licensed in anything besides holistic medicine, which I'm not putting down. I'm just saying that, you're going onto a platform hoping these people are updated, licensed clinicians, but you're finding that on YouTube there's not a lot of them. You will have some respiratory therapists that are actually licensed respiratory therapists, but then you'll have somebody who's acting like a respiratory therapist that was never licensed, never went to school. They just read a few things on an article. That is very common. So that's why if you go onto YouTube and you check us out, you obviously know that we're licensed clinicians. We're not going to give you jargon. We're going to follow by the book.
Right, we literally have a link to our website.
Yes.
Where you can look up, Alex, you can look up Dr. Shaw.
Yeah, and let's say you went on YouTube and you did some of the exercises that we did, that's fine. Because we know those are safe, but we're also licensed clinicians. We're licensed respiratory therapists and doctors. It's just, we have dietitians, we have cardiologists, we have pulmonologists, we have respiratory therapists. Well, there's a lot. We do a lot for our patients, but let's say you went on YouTube and you start doing some of the exercises, and then you asked a question on YouTube, on our page on YouTube. Most of the time we'll answer. I think we always try to answer all the questions that come up. I know there's a ton of questions that come up on there. It's kind of hard to, try to keep up with all the questions, but if you bring up a question or you even call us up, we'll give you the right answer. And if we don't have a perfect answer, we know to consult with somebody else to get a proper answer. But most of the time, we'll know a good answer. We'll have a good answer for you.
So, Alex, thank you for that segue, by the way, that natural segue, because I have a question from YouTube.
Love it.
That I really think is important that we answer because this individual is just, yeah. This comes from Marty Looking Bill 1264.
I know Marty. Hey, Marty.
From YouTube. He says he went to his lung doctor on last Thursday. Says his lung function is 18%, and she told him that she has no hope or faith that he can get better or that he can do any better. So he gives up. What should Marty do? What is best advice for him?
Okay, so who said that to give up?
He is, I think, frustrated and is giving up.
He's frustrated and giving up. Okay. Marty, if I recall, and correct me if I'm wrong, but if I recall, I remember you weren't able to walk much at all. And then you went up to a high volume. You went up to a higher walk rate. You were walking a lot further. I mean, hundreds and hundreds of feet. If I know that. I remember that. So how are you getting worse? How are you getting worse? The thing about giving up that a lot of people do is I know it can be frustrating because you're handling a lung disease that is a progressive lung disease. Okay? But you don't have to die that way. Okay? You don't have to die that way. If somebody gave up, I mean, it's when you're so close to a finish line, but you give up just before that. And that finish line might seem like it's a mile away. But giving up should never be in your vocabulary. Should never be part of you. Giving up is what everyone else does. They try to eat just food and they think, oh, let me eat this and that's going to get me better. Let me take this pill, and that will make me better. When they realize that it is not getting you better. It relieves probably symptoms that you've had maybe. And maybe you take a medication for increased bronchoconstriction, and you take albuterol, and that alleviates those symptoms. That's different. Okay, giving up should never be part of your vocabulary. The easiest thing to do is to give up. It's the easiest thing. It's just to give up. And Marty, if I recall, you are not that type of person. But right now, there's that little thing on your shoulder, basically kicking you in the head, saying, "Just give up." So easy to give up. It's so easy to quit. You can't quit on something that you're improving. That's my point. You're improving. Why would you? Don't ever take those types of words that projected towards you, that's communicated towards you as, this is the best I can do. That person should not be saying something like that to you, ever. They should never tell you to give up. What kind of health care is that? I mean, like literally, what kind of health care is that? That's not health care. Who'd you talk to, a mortician? That's not health care. That's not even... how are you caring? Health care. That person should never even be licensed. I've met a lot of people in my line of work, and I've met a lot of clinicians in my line of work. And when somebody gives up, what comes in my head is when a nurse practitioner, an NP, nurse practitioner, comes up to me and says, "What's the point of you doing rehabilitation on that patient that hasn't moved?" I says, the patient does move. Not as well as you want, but the patient didn't want to give up. He said, but what kind of quality of life is that person going to have? And I work on those people that they ask me for help. I work on them even though all these doctors and the nurse practitioners, not every nurse practitioner is like that. But there was one specifically that told me I should just give it up. I said, if you wanted to give it up, then why don't you write the order? I can't. And why not? Because it's illegal. I can't write an order like that. That's what they will communicate with me. There is no order like that. They can't write an order, the patient gives up. You could go to hospice care, comfort care, but in health care there is no such thing as giving up. Because the person wants to live. And we're going to do everything. That person that couldn't walk, I got that person to walk. And of course, the nurse practitioner didn't care. Because their first mindset was to try to always prove me wrong. I hate that. We're in healthcare. We're supposed to be a team. If that person wants to live, we should do whatever we can for that person to live longer, better. And what kind of quality of life? Well, I got the person to walk. The person now realizes more than just hope. I mean, if somebody says giving up, it doesn't make any sense to me why you would give up. It would be different if you're bleeding out and you're dying as it is. But even then, Why would you give up? If there was a little bit of hope, why don't you take the hope? But I hate the word hope. I really do. Because in our program, we don't rely on hope. We rely on results. You know, you can hope this gets, and a lot of people's mind frame is like that. I hope I get better. No. You better not hope you get better. You're going to do the work until you get better. And I mean, like, look at our success rates. You think all those people didn't think of giving up? You think about all those people that didn't get that you think they've never thought about giving up? I would say almost nearly 80% has thought about giving up, maybe even higher than that. But those people did the work. As you can see, they're graduated. Those people, if they actually gave up, they would have never see the graduation. They would have not see themselves going further. I mean, giving up should have what? The martyrs of history. I mean, like, what should Christ have reduced the cross? Should Gabriel told the all the Jews to kind of just give up and live on their knees in slavery? Should we just have reduced should we just give up on everything we've ever done? I mean, should we just, I'd rather lay on my knees and just take the beatings all my life, or fight for a freedom that I realize exists, but in the back of my head I realize that it's going to be tough. Look at me, for instance. Okay, look at me, for instance. I have done what in my life? I have became a top leading respiratory therapist. Top 1% in the world. I have. Top 1% in the world. I'm becoming a pilot. I'm an advanced diver. I have been in the military, Army, 1999, Fort Knox, Kentucky, 42nd Infantry. I have done marathon running. I have done long time, every single possible thing that you have a certification to, I have done it. Back in my head was never give up. In my head, it was, this is going to be difficult. But it's doable. I have to set my mind in what I need, and I don't care about what anybody else would say. Alex, you can't do that. Alex, you can't do that. Alex, this can't happen. I mean, we revolutionized pulmonary rehabilitation in itself. HRN has. We've literally done so much for people, and we've transformed pulmonary rehab to a higher success rate. We're just waiting for everyone else on board with it. Everyone else, I'm talking about other clinicians, to learn the things that they didn't know that could be possible for a patient, for better outcomes of that patient. So giving up should never be in your vocabulary. Should never be a word in a dictionary that you use. Ever. You're closer to the finish line than you think. But if you're thinking that I want to be exactly what I was when I was 12, and you're 60 years old, that's different. You don't ever want to... You're not going to be a 12-year-old. Because you're in your 40s, you might be in your 60s, you might be in your 50s, you might be in your 70s. Well, when I was a kid, I never got out of breath because maybe you were, maybe you were 90 pounds, not 200 pounds. Don't give up. It's the worst thing you could ever do. You've lived longer right now because you didn't give up. If you gave up, then all else ends. Everything ends. Everything. And what's going to haunt you is the fact that in your mind is telling you, just move a little bit. Just breathe a little bit. Your brain, your body doesn't want to die. Regardless of what you may think, you feel like you're one entity, but you have a billion cells that are working for you. You give it warmth, you give it love, all these little cells. You give it food, you give it everything it needs. It doesn't want you to die because they don't want to die. It's a shame that you want to. It's a shame that you want to give up. Don't give up on something that you're closer to than you were before. That's all I have to say to that.
I think that's a good message to leave and sign off on, which is never give up. So thank you so much, Alex.
Thank you very much,
that's,
everybody.
That's all we have time for today. Everybody, thank you so much for tuning in. It's time for us to tune out. I've been John. Adieu, adieu.